All right, so do we have, good, most people are back in the room. So a couple of things that I'm going to do is try and give some theoretical frameworks for kind of what's going on. Because what you're seeing is, just like with any practice of psychiatry, is that there are lots of variations. So something's very different if I'm working at NYU in the CPAP, and I kind of have all the other doctors there, I have the equipment there, I have security there, like all that stuff's already taken care of for me, and I just kind of work in and see the patient and then leave. That's very, very different than if I'm on a mobile crisis team running around, in a van going into people's homes. If I'm going into people's homes, who knows what I could see there? They could, have other people in the room. They could have, a gun on the wall. They could have access to weapons and stuff that they might not have if they came in to a hospital. So just like any other practice through video has many different variations, and you really want to sort of be very aware of what kind of practice you want to build and what kind of context you're working in, because that's going to impact the decisions you make about other things. So I'll try and keep, what time is it now? It's 4:15, we go till 5:30, and we want to have time for a demo. Okay, I'll try and go until... so just so everyone, I printed out my slides so you all have them, because some of it's a little more you want to reflect upon it, and also have it as you're building your practice and thinking about things. So here's my contact information, the Wi-Fi. You want to turn it? So just my affiliations and disclosures, which is some of the best part of it, is this is kind of who I am and what I do. To some degree, I'm the Director of Supportive Televisiting Services, so that's here at the New York Society for Ethical Culture. We connect children and teenagers with their incarcerated parents through telepresence. We also build in more clinical supports for the families and the person who's incarcerated, like anger management, parenting, stuff like that, and it's all through video. I also am the president and co-founder of Healthy Connections Psychological Services. So that is a new company I started over the summer, and it does exclusively telepsychology. So we do assessment and consultation through video, and that's also actually from here. I have one of my units here. And so in the mornings, I go in there, I turn on the computer, and I beam into a skilled nursing facility in upstate New York, which is way up by Canada on like one of those big lakes. And it's a really cool thing. So I'm actually like doing this stuff on an ongoing basis, which is really exciting. And I also collaborate with psychiatrists, so we do telepsychiatry as well. I also, my own company is called Frank J. Corigliano, Psychologist PC. I also see patients at the Institute for Human Identity, which is in Chelsea, and that's an LGBT-focused therapy center. And one of the projects that has kind of had fits and starts there is building a statewide LGBTQ therapy center, so taking IHI statewide. So those are some of my income flows and some of my projects and some of my passions, which, if you can get those three things aligned, that's a good thing. Thank you. So just a little context about where you all are. You are all psychiatrists, yes? Okay, good, because we have a horde of like 6 pastors that are running around, and I don't know what happened to them. But they'll be joining us at some point, if not today, then next week, I hope. So telepsychiatry is a subset of telemental health. Does that make sense? Within telemental health, you might have telepsychologists, telesocial workers, and then within telemental health is a subset of telemedicine. So telemedicine, you might have teledermatology, which is really big, telecardiology, all the other practices of medicine. And then telemedicine is a subset of telehealth. Telehealth is a broader term that's not just medicine. It also includes wellness, fitness, that kind of stuff. So does that all kind of make sense? Just to give you some language and some context of where you are. Good. So current applications of telepsychiatry in schools, hospitals, prisons, and the military, and also places of work. These are sort of the big active playgrounds that have adopted telepsychiatry. Next. Emerging applications are community centers, churches, temples, mosques, emergency response centers, homeless shelters, and going completely mobile, direct to device. So these are some of the emerging things that you are already thinking about. Okay. Some models of telepsychiatry, I need to make that bigger, and this matters, and I want to have it on paper for you so you can really appreciate. Are you doing an institution to institution model? Are you connecting from Bellevue to another Bellevue satellite site in Bed-Stuy? Is it institution to institution? If so, you're going to have some structures and infrastructure there that would be very different if it was institution to individual. So institution to individual would be Mount Sinai working with a woman with breast cancer in her home. So that's institution to individual. So with that, you have that institutional structure. So you might have the room set up, you might have the medical records there, you might have a nurse on staff, you might have all these things that, like the whole video stuff is set up for you. But on the other side, who knows what that woman has going on in her house? Who knows what kind of equipment she's using? You have to figure out what software she's going to have. You have to figure out what the privacy and safety issues are in her home. You have to know all that stuff. So do you see how things change very, very quickly when you go from institution to institution to institution to individual? Yes? Yeah, good. And this is giving you some context to think, okay, where am I playing? What is my model? And then you have individual to individual, which that's, private practice psychiatrist connecting to private patient. Individual to individual. That means you got to have all your stuff nailed down because you're not walking into the room at St. Luke's that's already set up and all, connected and stuff. You got to set up your own stuff. And you have to know how to set it up for the patient as well. So that's why you need to have that competency to be able to figure that stuff out, to troubleshoot, and you might want to look at getting other professional support to help you with that.
Do you have models for like a private practice to a hospital?
So that would be individual to institution, right?
So it's still going to be institution to individual, kind of like that.
Oh, so right, it'd be a flip.
Oh.
Yeah, so institution to individual or individual to institution. Yeah, so where the individual is the doctor and the institution is where the patient is. Yeah, so that's what I do. That's one of the things I do. So I'm an individual doctor who sees a patient at an institution, skilled nursing facility.
Okay.
So I beam into skilled nursing facilities, and I have all the support of the skilled nursing facility. They wheel on my patient, put them in front of the camera. I say, hey! And I always check the weather first. And I check what's going on at that facility, because I want to know what time bingo is, because that can be a really good motivator in a session. So those are and I say that sort of jokingly and sort of offhanded, but that's what you want to do. You want to know what the culture is and what the experience and the environment is where the patient is. That's your job, because those things will impact everything you're doing. Good. So here are some of the obstacles you have in print as well. So technologically, you could have difficulty seeing or hearing the patient. You might have poor recruiting. You might have mistrust of the medical community. This shows up better on the next slide. Oops, sorry. I think. Challenges to access to mental health care. So one of the big things about tele is that you can break down the barriers to access. So some of the accesses are, or barriers to access is the emotional barriers of stigma, shame, guilt. So when we think about our patients, what's keeping them from coming into our office? Or we think about our dream patients. We think about that, that guy with a history of, sexual abuse trauma, and why is he not coming into my office? I know they're out there. Maybe it has to do with, access related to shame and stigma. Maybe it's cost prohibitive psychiatrist fees. Maybe there are cultural barriers related to independence, denial of problems. Maybe there's a cultural mistrust of doctors, especially maybe doctors who don't look like them. or sound like them. So this is also why it's so interesting to partner with folks like the Black Psychiatrists of Greater New York, or LGBTQ folks, or to really start leveraging our cultural competencies to really build our practice in a way that is meaningful to us and reduces burnout. Physical challenges for older adults, history of inconsistent, unclear, and often harsh attempts at community engagement. So a lot of times we haven't been great at reaching out to communities. Inconvenience of traveling to a clinic, hospital, or office. And there's a limited number of trained psychiatrists. So these are all barriers. So how do we really make the most out of who is trained and who is willing to work with folks? So we all know these are some basic things that psychiatrists can help around.
Oh,
We have to do a little quicker.
no, this one's blank.
So here are some of the theoretical underpinnings. You're getting a lot of bits and pieces of, like, you'll have a random question. What about licensure? What about this? What about, prescriptions? What about... So this is going to give you a little bit of a theoretical underpinning. These are kind of the things that you want to think about when you're building your practice. You want to think about the legal implications. You want to think about the ethical implications. You want to think about financial implications. Who's paying me? Am I getting paid? Is this grant funded? Is this insurance reimbursed? Is this private pay? If it's insurance, which insurance? Is it Medicare or Medicaid? Is it private insurance? So all those things you want to be thinking about. The cultural implications. Are you dealing with a tech-savvy culture? Are they going to take to this very readily, or are they digital immigrants? So the difference between a digital immigrant and a digital native is generational, whether you grew up with technology. The current technology, because we always grew up with technology. Then you want to know the technical issues involved. So a lot of this sort of like, what is encryption? What does it mean end to end? What's the difference between software and hardware? You want to get
Clinical.
all that. You want to know the clinical issues, thank you, that are involved. What does it mean to have a patient that I can't hand a box of tissues to when she's crying? What does it mean that I'm doing family therapy with a family where mom's in jail and she's beaming in on a big screen TV and her little daughter is crying? And how do I create a clinical relationship? How do I bridge? So this is one thing I do in telepsychology or televisits, is I'm constantly teaching the families how to bridge that connection. So one of the things is I have mom, so here's the little guy over here, and he's not really connecting with dad on the screen. And dad's feeling a little alienated, and mom's feeling I have to make this relationship work, and the kid's saying, what is going on with all you people, and why is dad so big on that screen? Because I have a huge TV. So what I told mom is, Mom, sit down on the ground and sit right next to the screen and right next to the camera. So you're going to leverage your relationship with the child, and you're going to direct it towards dad, and you're going to bridge that relationship. And so then you're going to be sitting there casually, just noticing you're having a conversation with dad, you're turning to the son, and you're sort of engaging, and you're leveraging that. And as opposed to, talk to dada, look at dada on the screen. So you really want to be aware of the clinical implications of technology and how to leverage your relationship and how to, just be aware of all those things. And you want to be aware of the social issues and the psychosocial issues, things like economics, who has access and is really good at getting technology versus who has never had a computer in the home. Those kind of things. Right. And then here's some of the more factors to consider. Read that at home between sessions, and if you have any questions or want more details, we'll talk about it next week.
Can you please email it to us because it's cannot viewed on the handout?
Yeah. Yep. Continuum of community-based care. So one of the ideas for this project is really training psychiatrists, and we have a connection. We're looking at connecting to churches in Brooklyn and doing consultations and being able to do that. So you want to look at what is the level of care? What am I doing here? Is this a consultation with telepsychiatry, just offering a consultation with faith-based leaders? So like a pastor says, I have this family, they're coming in, there's a lot of addiction going on. and I don't know what to do. So you can offer that as a consultation. Oh, well, you know, it sounds like this person is just sad. It'll, you know, keep an eye on them, offer them support, get them integrated in the community. Or, you know what, that sounds like that person is really struggling. You're seeing marks on the arms, you're seeing other things, you know, let's bring them in. So you really, you could do a community-based assessment where you're actually working with the patient through video. So the church could have a video room set up and they bring the patient in. And you're like, hi, I'm Dr. You know, Wonderful, and aren't I great, and you're wonderful too, and let's work together. Yeah.
I've done a lot of work with the religious over the years. Nuns, priests, hookups with different communities of state, also individual groups and whatever. I want to really stress the importance of this connection, first of all, out of my experience. You see, whether you're a psychologist or a psychiatrist or a psychiatrist, psychoanalyst, as I am, of the interpersonal school, the first thing you have to pull on with a patient is the belief system. And I think in all of our disciplines we've seriously underrated that factor. We call it placebo, this, that, the other thing. But the truth is, unless you from the beginning begin to talk with the patient about their hope and resilience, you don't have the red thread. And these communities are the people that can help you get that. And if you can establish a connection there of any sort, and telepsychiatry should be, I think, very important here, you will have a backup that is similar to what you can do with a backup from group therapy or CBT group. I really am happy to see this.
Yeah. Yeah, it's one of the, when we look at the emerging places of practice, how we reduce barriers to access, it's going to the community-based stuff. So you could also do, and then you want to think, are you doing long-term care or are you just seeing them for a few sessions? So maybe this is a rural clinic that, you know, that doesn't have access to a psychiatrist, and so you're just going to do a few sessions, and then maybe they'll go somewhere else for ongoing care. That's not a great example, but you get the sense of know whether or not you're doing short-term treatment or ongoing care. The other one is ongoing treatment. So that's you're doing ongoing care, and you may have in-person on-site visits, or you may not. You may never see this patient. So really getting aware of what sort of a model you're looking at and what you want to get into, because they all have different implications. So for example, if you're doing you know, short-term treatment, it might be that, you know, the licensing thing isn't as big a deal because the state you're going to be in has reciprocity for up to 30 days. But if you're looking at ongoing treatment, that's a different model. If you're building your business to offer ongoing treatment, then you really need to be looking more at maybe getting permanently licensed in that state if that's what it requires. So depending on what your model is, there's going to be different implications. So this is the 5-service model, and it gets kind of washed out. Our screen's kind of weird. But this is what I want you to be thinking of is I think of 5 services when doing telework. So we have teleassessment. So that's things like doing triage for depression, anxiety, trauma, any sort of assessment work that you want to do. So that's a whole thing. What do you offer? I offer teleassessment. I'm a psychiatrist who offers assessment. I can do assessment in jails. I can do assessment in churches. I can do assessment in your emergency clinic. I can make determinations about whether or not they need to go inpatient or if they're fine going home. So teleassessment. So that's one huge sort of service that you can offer. The other one is intervention. So that's psychotherapy, medication management, coping skills training. I offer an intervention. That's something that I offer. So those are two of the things I do. I do assessments and I do intervention. Another one is supervision. So if you have specialty supervision, for example, working in disaster response or a particular type of trauma, or you're really good at smoking cessation, but someone else isn't, you can fill your practice by offering supervision through video. And it's really exciting because you know what, you're really good at this, and you really love this thing. And you know someone else isn't so good at it, but you really want to help get them up to par. So you can do telesupervision. Consultation. So if you are working with an organization that doesn't have the skill set that you have or the competencies that you have, you can offer to do a consult. Those things tend to be short-term, sort of case-based, that kind of thing. And then psychoeducation and training. So you can do telepsychiatry in services, you can talk about self-care and healthy behaviors, you can do training through video, and then you can open up your audience very wide. So these are what I'm trying to do is we've had a lot of random stuff, wonderfulness, trying to give you a little structure. So these are really start thinking about what is my menu of services that I'm offering. Like, am I offering supervision? Am I offering therapy? Am I writing scripts? Is this short term? Is this long term? Is this going into the house? And am I offering it to, you know, NYU? Like, what am I doing? Yes.
This probably may apply to any of the models, but particularly to the assessment and to the, I guess the second one is intervention?
Yep.
Yeah. What do you make some kind of contract with the patient? And this is particularly true if you are seeing somebody who is great distance from where you are. But what's your, in terms of someone who on a session you certainly are not saying, but you see that they're suicidal. What kind of contract do you make with your patient that how you will deal with that?
Right.
I mean, that's the question I have in terms of, you know, because if that, I would think that you'd have to make some kind of contingency contract with your patients, and particularly if you got depressed patients. I mean, that question just comes to me.
Right, no, that's really good thinking. You want to think about what the difference is between, you will very rarely hear me say one thing is better than another, or that you can't do anything, just as a rule of thumb and a lifestyle choice. I tend to work from a yellow flag, not red flag model, which means I generally don't say no, I say what would need to be done to support that happening. So for some people, they would say there are certain patients who you cannot do distance work at. You can't work through video. There are certain patients. That is not true. If you look at ATA, it says very clearly there has been no patient group or category or subgroup that it is contraindicated to do video-based work. And in fact, some studies are showing that people might feel safer doing work through video because there's this emotional distancing that happens. I see it with my kids. You know, when they're talking to their mom or their dad, sometimes they feel emboldened. They feel like I can yell at you, you can't hurt me, I can be freer, I can be more open. So the one thing I want to do is sort of pass along a little bit of the yellow flag, not red flag. Think about if you think about certain risk factors such as suicidality or working with people who are extremely depressed, what supports can you put in place to be able to work with them effectively?
Borderlines.
Yeah, borderline. Patients who carry a borderline diagnosis, you know, they have phone sessions. They have a lot of things. This is a wonderful way to work with people because you have that availability. You can read the visual cues. You can look at the context of the environment they're in at the time. There's a lot of benefits to it. One of the things we will do is we'll talk about an emergency plan. Everyone will leave here with sort of a template emergency plan, which means if you're doing work at a distance, you want to know a few things about that place. So you want to know the local hospital that has psychiatric capacity. You want to know, have a local person there, an emergency contact who in the case of emergency, they can do something about it, and that'll vary depending on what model you're using. If you're going into the home versus if you're working in a hospital. So at the skilled nursing facility, I know if my patient gets suicidal, I just call them and say, get in there. But if that patient's in their home, is like a homebound person with hoarding, and I'm working with them and something happens, I need to know maybe the neighbor's phone number, definitely whether or not 911 access is in that community. I want to know what those resources are, and I want to have a written plan for every patient, because I don't want to have a problem. So in terms, I want to be sure that, and also when I was working on one of the telepsychology projects, we were looking at, we had this really lovely idea of like, if anyone gets suicidal, we'll just transfer them to the suicidal hotline. And so then we went down to like the suicide people, and they're not doctors, most of them, and they're like, you are a doctor, you need to learn how to deal with your patients. Yeah, and it was a really wonderful shift that we sort of had that, we should have this training, who best to work with our patients. No, just me. Who best to work with our patients. We need to know how to work in the moment with all of our patients' emotions and risk factors, and have a plan. Because one difference between in person in my office and you being remote is I can't tackle it. That's like one of the few things that you can't do. I can't physically touch or tackle you if there's a problem.
I have a quick question, because it looks like the models, the service models have a wide variation. The same legalities apply to each one of them?
Right, so you want to look at the context, all those things that feed into telepsychiatry. You want to look at each one and see how it impacts your model. So for example, and I think I'm going to add a couple of slides. One will be, so one of the big barriers is if you're going out of state.
Right.
So for the Institute for Human Identity project, for the LGBT taking it statewide, it's taking it statewide. We're not going out of state. We're not even looking at that anytime soon because there are so many issues related to it. Mostly, and you want to look at the legal issues, the cultural issues, the financial issues, you want to look at all those things and see how that impacts your model. So it's giving you sort of a framework to start mapping out your questions and your solutions.
The
Yeah,
teachings.
is there something over here? No? I'm sorry.
The last one.
Yep.
Do the same. If I'm going to do, let's say, some supervision,
Yep.
some wellness training,
Yep.
I want to give a grand round on telepsychiatry
Yep.
somewhere, do the same legalities apply? Because I'm not seeing patients,
Right.
I'm not dealing with patients.
Right.
So what happens then?
Right, so if you're doing supervision, that's practicing psychiatry.
Ah.
At least within the scope of psychology, that's
Okay.
practicing psychology.
Okay.
So if you're practicing medicine, you want to be licensed in the state of practicing it. So if you're supervising someone, you want to be licensed in that state.
Okay.
If you're doing a grand rounds and it's more educational, then that might be different. That might not be considered practice.
That raises another question, and
what
just
are
to piggyback,
Mhm.
if you're doing supervision, do you have to make have some form of contract with your supervisee?
Yes.
Right.
Yeah.
Yes,
Yeah.
absolutely. Yeah.
That's
Yeah.
what I'm asking.
Yeah.
Oh,
And these
okay.
are wonderful. I'm
Exactly.
Yeah, no, it's great that you're thinking about these things because supervision is a great way to fill in some of your time in practice
And there's a
and
need.
share your love of what you're good at.
Need.
Yeah, and there's the need, to train the future professionals. Good, so I think if there's a couple of questions and then we'll do a demo. Sound good? Any questions on anything I've said or sort of outlying questions that have not yet been answered? I'm not good, huh? Oh, wait, no, we got one. What is
I know
it?
you said that you found that patients are not only not, they're not only not, hesitant to talk, sometimes they're more open. So I imagine that's some, but do you find that there are some groups that, it's not complicated, but it's more difficult to get them to warm up to the equipment and the distance of technology?
Yeah, I think for people who aren't familiar with technology, they might struggle. So for example, in the skilled nursing facilities, they're not great techies, and I'm talking about the staff more than the patients. And so what we actually do is the units that we send to the skilled nursing facility, everything is super glued. They cannot touch a button except on and off. They cannot touch the little Zoom, they cannot touch the little this, everything is super glued. And so it's not a no, it's not a red flag, it's a yellow flag. What do I need to support this facility? And so it might be the same way with a patient. If you're working with a patient who's just not that good at technology, you might want to get them a unit that is set up very simple. All you do is kind of hit this button and it turns on. Or find out what their resources are. Like, do they have a grandchild who can come in and install the software and stuff like that? Or hire a service that can offer some of that setup and backup. Yeah.
Some of my initial reservations about telepsychiatry was that I feel like when I'm with a patient one-on-one in my office, I feel like all my senses are operating in terms of the assessment. And one of my initial reactions was that somehow or other that is diminished the ability to perceive that something that I might not perceive, that I might perceive if it was like sitting next to her, or I can look at her and see she has a nice glow in her skin, that I might not see that on the screen or as it might relate to some diagnostic piece. That's the question. That is a question that I have, and is that a function of the video equipment or that question of missing something that on a one-on-one setting, would I miss that?
Yeah, things will be different, and then I'll give sort of the bigger picture. After we answer this question, we'll have Dr. Hyler say a couple of things, and then we'll do a demonstration because I want you to see what it looks like. And then in between sessions, between this session and the next session, I want you all to buddy up. So everyone leave here with a buddy and practice, what do we say, 45 minutes of on video, on camera work with your buddy between next week. So before you leave here, you will buddy up with someone else. You will practice at least 45 minutes on camera and before next week. And if you have problems, you'll get in touch with me. Does everyone have Jabber installed? Is there anyone who does not have Jabber installed? Everyone has Jabber installed. Has everyone tested it? They called someone?
I thought I had tested.
Yeah, I think it's in the instruction sheet.
Oh, yeah.
You'll connect with the room inside,
Yeah, I called.
and you'll recognize it.
Yeah, did everyone see the bear and the spiders?
No.
Okay, so make sure you see the bear and the spiders.
I tried calling you for good directions and it said that you denied my call.
That's exactly.
If I'm not on, if I'm not on, then it'll, like, I have to, yeah, it's more if you call me, like, on the phone. Or if I know and I'm on video, because otherwise it might be in my bag, it might be over there, it might be anything. But the room is always on. That's set to auto.
Call the room just to make sure your connection is working correctly.
Yeah.
You'll see the room. Let me just say a couple words before we do the demo, because I alluded to it, but I didn't give you the correct information. This is for Dr. Davidson. You wanted a job, right? All right. I'm going to give you a job. So you want to do telepsychiatry from your office and get paid for it?
Yes.
Does anyone want that? All right. I have the name of 3 different companies that will actually have jobs, and you could look into them. First one, it's called Insight Telepsychiatry. Just like INSIG.